All right. So picking up where we left off on our next Clostridium species, Clostridium perfringens. This is your gas gangrene or food poisoning. I want you to lean into gas gangrene because it's just unique. But these are large gram-positive bacilli. They have more stubby ends. They are encapsulated. They have a capsule. They are non-motile. A reminder, tetany is motile. They're anaerobic like the rest of the Clostridium genus, and they're grown quickly on specified media. Again, Nagler reaction can identify them, but I think that's low yield. For transmission base, they're found in the soil like tetany. The vegetative cells are members of normal flora in both the colon and the vagina, but they are associated with war wounds when they get through the skin and can actually break out and start to divide and cause their gas gangrenous nature. They do this because of several toxins. So they have an alpha toxin, a beta toxin, and an enterotoxin. These are all exotoxin. The alpha toxin is phospholipase C and lecithinase. It's the most important toxin to know about Clostridium perfringens. What it does, it's going to lyse red blood cells, platelets, leukocytes, and endothelial cells. So breaking down vasculature, breaking down platelets, clotting factors, breaking down blood cells themselves, and breaking down our white blood cells. Because of this, it allows for increased vascular permeability, literally breaking up the lining of our blood vessels. And that's going to lead to massive hemolysis and bleeding and tissue destruction. You'll see also hepatic toxicity, myocardial dysfunction. This is your major player, your major destructive portion of Clostridium perfringens. Beta toxin is responsible for necrotic lesions and necrotizing enterocolitis. It has similar actions in that it can lyse some cells, but it's more specific to location versus this is more widespread alpha toxin. And enterotoxin is produced in the colon and is related to food poisoning. So for the food poisoning version of Clostridium perfringens, enterotoxin is going to be your exotoxin of choice. But when we think of like gas gangrene or the really kind of necrotic tissue pieces, we think of alpha toxin for this condition. So looking at pathogenesis, alpha toxin are lecithinase and our glycogen metabolism. We can see here binding to its receptor, getting taken via endocytosis, being inserted and created into this kind of pore formation, and then essentially inserting and starting its cleavage components. Its metabolism, it creates this gas in tissues, which literally creates crepitus through this process of binding and reproducing and recreating itself. It creates these little gaseous spaces. And so we can actually see in the Clostridium space, we can start to see these actual like gas holes. And this is the gas gangrene that we hear about. And so if you push on a tissue that's infected with Clostridium perfringens, you'll feel on your fingers like air is moving from your fingers. Food poisoning version, obviously still not great. Transmission is in soil and food. It can survive cooking because it's a spore. It can grow to large numbers in reheated food, and especially in reheated meat. The enterotoxin is really what causes your pathogenesis inside of people, and it's a protein in the coat of the spore. And clinically, you'll see after about 18 to 16 hours, watery diarrhea, cramps, not a lot of vomiting, typically resolves within 24 hours. So it is a pretty quick move through your virus. This would be like your 24-hour flu that goes through you. And then last but not least, our infamous Clostridium difficile. This is, again, gram-positive spore-forming bacillus rods. It's an obligate anaerobe, so it does not like oxygen. And in about a small portion of adults and a lot of children, less than 12 months, it's part of normal, healthy gut flora. So this can be commonly found in children, not commonly found in adults. Some strains can produce toxins A and B, and the toxin-producing strains are the ones that cause C. diff infection, so Clostridium difficile infection. It can range from mild, moderate to severe, or even fatal. So there's a broad range in clinical presentation. Transmission is fecal-oral spread, so contaminated hands of healthcare workers is common, and or contaminated environmental surfaces. We often see this also spread person to person in hospitals. And the reservoir is humans, colonized or an infected person, and a contaminated environment. The spores can survive for up to 5 months on surfaces as fomites. So these can have spread if you don't wipe down surfaces appropriately, which is why we always wipe down the table after every patient. So ingestion of the spores, germination and growth inside the gut. They'll then start to alter lower intestinal flora because typically if after antimicrobial use, if you have altered intestinal flora, that will allow for the proliferation of C. diff in the colon. So the big risk factor is someone who's just been on antibiotics in the hospital and then gets exposed to C. diff bacteria. And then if they do have the toxins B and A, that can lead to colon damage, a pseudomembrane, all of your gastrointestinal symptoms that you would expect to see in a gastroenteritis. So clinically, diarrhea. This is an example of the pseudomembranes that could form on colonic mucosa. And these are visualized via scope. That's how you would see them. You wouldn't know about this otherwise. You'd have to scope the patient. Okay, super fun, C. diff. All right, so now we're going to test our knowledge on our last two species, our spore-forming species, and then also combine our knowledge from before with our cocci. So a patient was hospitalized after an autoimmune accident. The wounds became infected. The patient was treated with multiple antibiotics. 5 days after the antibiotics was initiated, the patient developed severe diarrhea and pseudomembranous enterocolitis. Antibiotic-associated diarrhea and the more serious pseudomembranous enterocolitis can be caused by, this should be a big one, yep, C. diff. Just the one we just learned. That's your kicker here is antibiotic-associated diarrhea. Or if you hear pseudomembranous enterocolitis, C. diff should be top of brain. Symptoms of Clostridium botulinum food poisoning include double vision, inability to speak, and respiratory paralysis. These symptoms are consistent with invasion of the gut by Clostridium botulinum, secretion of an enterotoxin, endotoxin shock, ingestion of a neurotoxin, activation of cyclic AMP. So this is food poisoning, and then it's dealing with these other symptoms. So what do we think it's consistent with? You said D, you are correct. So you want to say secretion of an enterotoxin because they say food poisoning, but you have to look at the symptoms, right? We're dealing with neurologic symptoms, double vision, inability to speak, respiratory paralysis. We're starting to think of like our cranial nerves. And so neurotoxin is going to be your best answer here. We're not dealing with shock. We're not dealing with low blood pressure, passing out, hypotension, severe fever. We have nothing to indicate activation of cyclic AMP. And then sure, we could have invasion of the gut epithelium, but that doesn't tell us like why specifically these symptoms are consistent with these specific things. I would expect, food poisoning to give me vomiting, diarrhea, stomach pain, those type of symptoms. So that's how we get to D being your best answer. The most common portal of entry for C. tetani, this cause of tetanus, is the skin, GI, respiratory, genital, nasal. Correct. You said the skin, step on a rusty nail, you are correct. These ones here and here does not like oxygen, remember? So it's going to try to stay away. It's going to try to get into a place where it can kill off all the blood vessels around and then grow and fester without having to deal with a lot of oxygen. GI and genital would be good guesses, but it's not the most common portal of entry. Skin is. Okay. So we've gone through our spore formers now. Now we're going to look at our non-spore formers that are gram-positive bacilli. So Corneobacterium, we think of Corneobacterium diphtheriae or diphtheria being the disease it causes. And there are also other opportunistic infections by other Corneobacterium species that we can see, but diphtheria is like the most common one we see with this bacteria here. So it's a gram-positive bacilli, but it has a V shape. Sometimes it has a K shape or an L shape. So it has like a kink or a bend in its shape as a bacilli. It's not just a straight, easy bacilli. Almost like a Chinese letter pattern angular arrangement, I guess that's what someone's used. So you can see that here. Albert stain, I wouldn't worry about it. Loeffler's medium, I wouldn't worry about that. But it's non-motile, non-capsulated, non-sporing. So none of those things, right? So it's so far we're like, okay, doesn't look so bad. when we look at the clinical findings, we'll see it's common cause of diphtheria, nasopharyngitis, and its incubation phase is like really short, 2 to 5 days. One of the things that's characterized for making is this fibrinous exudate or pseudomembrane in the back of the throat. We see symptoms that include then this enlargement of the neck, the lymph nodes, and neck edema, even irregularity of our heart rhythm, as well as obviously difficulties with swallowing and speech. We'll see it can also cause corrosion of myelin sheaths. So it can affect the central and peripheral nervous system, which can lead to degenerating motor control. So this is our classic kind of diphtheria, that pseudomembrane back here. In children, it can be fatal if it's not treated in time. It's exclusively a disease in humans, and it's droplet spread, and it can be found as fomites on surfaces, although it can't live for that long. Really, it's once the droplet hits the surface, it's not going to survive for that long. I already mentioned these pieces, and then polyneuropathy, palatine paralysis. So how do we form this pseudomembrane? And the thick membrane that lines the throat, it can interfere with all the functions of the throat and the mouth. It has a combination of white blood cells, red blood cells, bacteria, and epithelial cells that are being broken down. And so that's like what actually makes up the membrane. The cause is this fibrinous, this fibrous exudate from local breakdown or cell death caused by exotoxins from the diphtheria, from the actual bacteria, can literally lead to all of the fibrin, leads to all these little molecules sticking together, creating that pseudomembranous membrane, essentially. And you could see it localized in multiple different areas. Typically, you see it localized at the back of the throat, kind of like at the base of the tongue, but it can be in other areas as well, but we typically see it back there. I think the kicker is it's multiple cells involved, and it's the fibrin release from this cell breakdown, from this necrosis of all these cells, from the exotoxin of the bacteria that is causing this kind of conglomeration of all these cells together to create this membrane. So the exotoxin involved, it's encoded by the gentox. It's from a phage, a bacteriophage. We'll see 2 fragments, fragment B, which binds the toxin, and fragment A, which actually does the enzymatic activity of breaking things down. So we see cluster, or the diphtheria here, diphtheria toxin, A, B, endocytosis, gets inside, breaks apart. This is the binding portion. So A goes inside, it inactivates elongation factor 2, prevents protein synthesis by the ribosome, so then you have cell death, which is necrosis, and then the process continues. So you'll see this occur again and again and again. That's your classic diphtheria. So diphtheria, again, remember, from our favorite Cordyobacterium diphtheriae causes diphtheria. And I think it's important. We often see it as C. diphtheriae, but NPLEX sometimes will give you the whole meal deal. So Corneobacterium diphtheriae causes diphtheria. So we remember. All right. Getting to our next, Listeria monocytogenes. All right. Small little rod, no capsule, facultative aerobic, so it can deal with oxygen or not. And it likes to be intracellular if possible. It kind of moves like a tumbling movement, and it creates a little small colony on the blood with a very small zone of beta hemolysis. So it can do some beta breakdown of blood cells. It is catalase positive and oxidase positive, which is why it can deal with oxygen. And then if we look at listeriosis, this is a serious infection that can be caused by eating foods like unpasteurized milk, cheese, deli meats that are contaminated by the bacteria. We typically see this affecting pregnant females or newborns or people that have weakened immune systems, not someone who's healthy. This is why the classic, like, don't eat a deli meat while you're pregnant piece has come onto the scene, is because of concerns about listeria or listeriosis. So if we look at this, we can see contaminated food, gut, lymph nodes, and then kind of this cycle here. So this could lead to like a meningitis or a sepsis. We can see this in fetus or newborns due to transmission across the placenta during delivery, so neonatal meningitis. You could also see this in immunosuppressed adults, especially ones who have received like a kidney transplant, renal transplant, because they have decreased ability for filtering through the blood. And infected mother, asymptomatic or mild gastroenteritis, but this would lead to like a spontaneous miscarriage or abortion in an affected mother. You may not see actually like a major big disease occur, except for loss of child, loss of fetus. So the organism, we find it all over, but these are like the things that are more likely to have Listeria hidden in them. And you can, I guess, have human contact, like transmission to humans by contact with animals or their feces, but because it is widespread. But again, typically we won't see a big gastrointestinal condition outside of neonates, pregnancy, or immunocompromised. Our Mycobacterium is interesting because it technically isn't a gram-positive, although it often gets classified with gram-positive bacteria because this is our lipid-rich cell wall, or acid-fast bacterium. It's aerobic, it loves oxygen, it does not move, it's non-motile, and it causes these granulomatous formations. And there's 3 important human pathogens. One that's really important, our Mycobacterium tuberculosis, TB, our Mycobacterium leprae, leprosy, and our Mycobacterium avium typically doesn't cross over into humans, although we'll look at it today. So Mycobacterium tuberculosis, it's primary tuberculosis. It's spread via respiratory droplets, coughing, sneezing, talking, inhaled all the way into your alveoli, and then the organism gets phagocytosed by your macrophages that live in your alveoli. The organism may not cause immediate infection, and it can actually wall itself off in a granuloma. It's called a Ghosn complex in the actual alveoli. Obviously, if there was these large complexes in those alveoli would start to become less and less efficient for oxygenation, as well as oxygen transport and diffusion and perfusion. So you would start to see potentially issues depending on where these bacteria have created these granulomas. You tend to see them up top in the like zone 1 of the lungs more than zone 2 and zone 3, but they can be seen in all 3 zones. Granulomas can break down though in the future, so even if they are walled off, anytime they could break down, and the organisms could cause an infection later on. So when we see an exposure to TB, we'll have infection in 10 to 30% of people, no infection in 70 to 90%. From there, the majority of people get a latent TB infection and actually never develop active disease. But about 10% of those, or sometimes more, could develop into active TB. After infection, 10% will automatically go into active TB. And then untreated versus treated. If you're untreated, you typically will see, you could see death after 2 years, or survival. Treatment, you could see death or survival. So there's a lot of issues with tuberculosis, and cure rates. A lot of this pertains to medication compliance or adherence and medication antibiotic resistance. So we have a couple different tests. You see this more on NPLEX II, although I've seen them throw something like this into NPLEX I, so I'm just going to mention it. The PPD test, if it's positive, it detects patient cell-mediated immune response to bacterial antigens. So past, present, or vaccinated. It does not tell you if the person currently has an infection, previously had an infection, or was vaccinated for TB. So these can often be inaccurate if a patient has had one of these other scenarios. Then they also have a blood assay, an interferon gamma release assay, which is a blood test, and it measures your specific immune reactivity to a microbacterial antigen. Again, past or present infection will come up positive, but not vaccinated. So the blood test at least will tell you if someone's been vaccinated, if they had a past or present infection, but it still can't tell the difference between the two. You actually have to do a chest x-ray to rule out active infection with people who have been exposed to TB in the past. I actually am one of those people. So I was exposed to TB in a clinic when I was working as a pre-med student in undergrad. A patient had active tuberculosis in the Portland metro and wasn't masked, wasn't diagnosed, and we were in the office not masked, just listening to their lungs, and then afterwards had to get masked, tested, etc. And to this, I never had active infection. I was treated for 9 months for suspected latent TB, which was fun. But then every time I do a TB test, either a PPD, although this often doesn't come up positive for me, which is interesting, but definitely the blood test will come back positive. So then I have to get a follow-up chest x-ray pretty much every year to prove that I don't have active tuberculosis, even though I've been treated. So it's fun. All right, that's my TB story. Mycobacterium leprae. This one is because it's been on this is on my NPLEX I. It causes leprosy or Hansen's disease. It's an infection of the skin, mucous membranes, and peripheral nerves. Most cases are in warm climates. The bacteria infects the cooler areas of the body, so ears, nose, eyebrows, fingers, and toes. And it causes like a glove and stocking loss of sensation because of the areas that it affects. And the kicker is the reservoirs armadillos. So that's like the one of the kickers here. The mechanism of nerve damage with our leprosy is it enters via blood vessels, causes that inflammatory response, and then leads to demyelination. And that's how the demyelination is what will lead to the polyneuropathy, that like glove and stocking damage that can occur. You can have tuberculoid leprosy. So these are the two forms of Hansen's disease. This is more of a limited, hyposensitive, hypopigmented, hairless skin plaque. They'll have a Th1 type response. So typically more of like infectious bacterial type 1 response producing interferon gamma. Also targets things more intracellularly, a type 1 response. This is a strong cell-mediated response, will clear the antigen, but causes tissue destruction locally. Versus lepromatous leprosy presents diffusely over the skin. It's communicable, so this is your spreadable form. You'll have a really diminished cell response to the actual bacteria. T cells will fail, macrophages will become disrupted, and you'll have issues producing interferon. They will do a type 2 Th2 cytokines and humoral response, which is more of an extracellular response typically. But it can lead to more of a diffuse skin lesion that can be harder to manage. All right, let's test our skills on some leprosy questions or mycobacterium questions. So there are millions of cases of leprosy worldwide, but predominantly in Asia and Africa. The clinical spectrum of Hansen's disease is best characterized by immunologic anergy, chronic pneumonitis, peripheral neuritis, bacilli and lesions that digest tissues, or erythematous lesions resembling concentric circles. Oof, man, that's a good one. I think I have an idea. Lock in your thoughts. Oh, good. All right, peripheral neuritis. That makes the most sense. That gets into the blood, inflammatory response, myelin destruction. That's glove and stocking neuropathy. That's your classic Hansen's leprosy. Because the lesions differ, right? All right. At a church supper in Nova Scotia, a following meal was served: baked beans, ham, coleslaw, eclairs, and coffee. Sounds great. Of the 30 people who attended, 4 senior citizens became ill in 3 days and 1 died. 2 weeks after attending the supper, 19-year-old girl gave birth to a baby who rapidly became ill with meningitis and died within 5 days. Microbiologic analysis revealed no growth in the baked beans, ham, or coffee. Many gram-positive beta-hemolytic short rod-shaped bacteria in the coleslaw, and rare gram-positive cocci in the eclairs. The more likely cause of this outbreak is, is it staph, listeria, clostridium, perfringens or botulinum, or non-microbiologic? This is a good one. So you have gram-positive beta-hemolytic short rod-shaped bacteria or gram-positive cocci. Lock in your answers. Here, if you said B, listeria, you are correct. So unlikely the gram-positive cocci and the eclair, that would be our Staph aureus example, probably not likely to cause like death in this way, right? Especially from an eclair itself. But when we think about what we just learned with listeria, it targets like that pregnant person probably wouldn't necessarily even know that she had it. She had maybe like a little bit of GI upset. We saw 4 senior citizens became ill and 1 died, so that immunocompromised people were more affected, and then the little neonate was more affected there as well. So that listeria is why. These 2 we'd expect for the actual host, the pregnant mom, to have symptoms if it was going to be either of these. These are spore formers. There wasn't anything that said anything about spore forming here, although the beta hemolytic, that could have led you away from these 2 and more towards listeria. And then this was just trying to throw you off the scent. Okay, pathogenic mechanisms involved in TB can be primarily attributed to what? Toxin production by mycobacteria, specific cell adhesion sites, cell-mediated hypersensitivity, humoral immunity, or clogging of the alveoli by large numbers of acid-fast mycobacterium. So what is the pathologic mechanism in TB attributed to? All right, if you said cell-mediated hypersensitivity, you are correct. Remember, this clogging of alveoli, while absolutely it can cause issues, that's more of how it protects itself and hides by making those granulomas. The cell-mediated hypersensitivity, the ability for our cells to become essentially reactive to themselves almost and to become hypersensitive to the response and cause this big symptom production, that's what really is going to cause the main mechanisms of active disease or active infection versus the hiding of the TB in not necessarily in the acid-fast mycobacteria. They're hiding out as they're digested or hiding out within those macrophages in granulomas. So that's kind of your kicker here. Humoral immunity is not dealing with cells. That'd be like antibodies and cytokines. We never heard about any specific cell adhesion sites, and we didn't hear about any toxins. So this is your best answer. A 2-year-old child was admitted to the hospital with acute meningitis. The Gram stain revealed gram-positive short rods, and the mother indicated that the child had received all the meningitis vaccinations. What's the most likely cause of disease? So you have N. meningitis group A or group C, Listeria, S. strep pneumoniae, and H. flu. So this would be kind of knowing what are common vaccinations, and then also understand, okay, it's gram-positive short rods. It's an acute meningitis. If you said Listeria, that's great. This is our non-vaccinated meningitis. So we have N meningitis. We haven't talked about them yet. We will soon, but there's vaccines for them. We have talked about strep pneumoniae. We haven't talked about H. flu, but we do have vaccines for all of these. So Listeria would be the most likely cause of this disease. And again, it's that short rod, that gram-positive short rod. The most common way TB is acquired is via the respiratory tract. That's a good one. TB can be found in the sputum of patients with TB, or the bacteria, Mycobacterium tuberculosis can be found with patients with TB. After digestion of the sputum, isolation is best accomplished by, this is a specific medium. Again, I wouldn't worry about the medium. If it was about the acid-fast stain, then I would care. Our Corneobacterium diphtheriae may be difficult to isolate from the nasopharynx without use of special media. The medium of choice is, again, a medium question. We're going to skip it. Loeffler's medium. All right. We made it through. While I'm pulling up my gram negatives, I'm going to see, okay, great. Any burning questions before I pull out my gram negatives I'm going to get 10 minutes into gram negatives before lunch. So those were all your gram positives. I think you can learn them all. I think you can know the bacteria, know some identification characteristics and their diseases. If you do, you'll be well on your way. We have more gram negatives that we're going to go through, and we'll kind of present them in a similar way. I'll start this before lunch for about 10 minutes, and then we'll finish up this one after lunch before we head into virology. So this will be a good lead in. So our gram-negative bacterial diseases, remember our cell wall breakdown. We have LPS, lipopolysaccharides. So we're dealing with our endotoxins now. But remember, gram-negatives can also have exotoxins as well. So we can see both. We have our outer membrane, our small cell wall, peptidoglycan cell wall, and our inner membrane. And this would be an example of what you could see a dichotomous key looks like for our gram-negative bacteria, with the bacteria that are bolded being kind of the most important players that we're really going to make sure we discuss in our conversation today. So we're going to start first with our Neisseria genus. And so we look here, some general characteristics. It's a gram-negative cocci. That's what GNC means, not the car brand, but gram-negative cocci. And it's actually a diplococci. So it has two cocci that are close together. It's motile and it's oxidase positive, meaning it can deal with oxygen. We'll see that it has fimbriae, a capsule, It has protease to inhibit IgA, so it can bind to mucous membranes relatively well. And it's going to have a oligosaccharide as well as its lipid A endotoxin, essentially, the LOS, the lipid A endotoxin, sticking off of its cell wall. This bacteria specifically thrives as well in high CO2 concentrations. It can deal with oxygen, so it's oxidase positive. It is very highly able to reproduce in places where we might not want it to be. The epidemiology, we can see it in its normal microbiota in the respiratory system. It likes oxygen. When it's pathogenicity, when it is in a pathogenic strain, we can often see it containing a capsule or that endotoxin when we see it being more pathologic. And the diseases for Neisseria meningitidis, the specific species, is meningitis or septicemia, which leads to death. Your classic characteristic or population for Neisseria meningitidis are babies under 6 months. That's the most common, then children, and then young adults. So that's kind of who we'll see classically get this meningitis, form of meningitis. You can treat it with antibiotics. And there is vaccinations to be preventing this. The other species of Neisseria is gonorrhea, and this is your classic gonorrhea. It's gonococci. You can see it affect eyes, pharynx, urogenital, rectum. It's really good at adhering to mucous membranes. Remember, it has pili also, and this protein too that can help bind to mucosal membranes. It also can get inside and replicate within a white blood cell, therefore hiding itself from detection even further. And the diseases are the STI, gonorrhea, septic arthritis, pelvic inflammatory disease from the STI, can lead to scar tissue and infertility, its complications. Neonatal conjunctivitis, especially passing through the birth canal of someone who was actively infected, and just general inflammation to urinary, repro, and oral cavities. So when we diagnose this, we could culture and isolate. The Thayer-Martin medium will grow Neisseria only. Chocolate medium also will grow Neisseria gonorrhoeae, although other things will grow in it as well. And obviously, we try to do screening, detection, prevention as much as possible with this. So a person who contracts gonorrhea is most likely to have acquired it via skin, GI, respiratory, genital, or nasal tract. The genital tract, that's the most likely place you're likely to acquire. It's the most mucosal place, the most superficial place for us to acquire it through. Neisseria gonorrhoeae is a fastidious pathogen and found in sites contaminated with normal flora. The best medium for isolation, we talked about this already, Thayer, Martin, agar, again, don't care. Neisseria meningitidis causes meningitis in all age groups. A characteristic physiologic trait is that it possesses the N-acetyluramic acid capsule and adheres to specific tissues by pili found on the bacterial cell surface. Has a capsule of polyglutamic acid, which is toxic when injected into rabbits, very specific. Synthesizes protein toxin as a result of colonization of vaginal tampons. Causes spontaneous abortion, has tropism for placental tissue due to the presence of erythritol and allantoic and amniotic fluid. Secretes 2 toxins, A and B, in large bowel during antibiotic therapy. What's its physiologic trait? You said A, you are correct. That specific capsule that I mentioned and its adherence factors, it has this ability to adhere to tissues. That's what makes it so effective at spreading disease. So that's our Neisseria category, our gram-negative cocci, okay, our Neisseria meningitidis and gonorrhoeae. Our next category we're looking at is our Klebsiella. Let me find it here. It's going to be right here in this picture, Klebsiella. So Klebsiella pneumonia is a gram-negative rod. It's a lactose fermenter, so it likes to use lactose in the form of energy. It does have a capsule, so it does have a capsule. And we can actually see that capsule here in this image. That's the bacteria, and then the capsule surrounding. Its reservoirs is soil, water, the gut, and the respiratory tract. And it has some pathogenicity in that it has a polysaccharide capsule, which makes it pretty, able to kind of evade the immune system pretty well. We'll see it, where I've seen it clinically is either in a UTI or pneumonia, often a hospital-acquired UTI. Pneumonia, you can see it in patients who are potentially immunocompromised, and it's classically seen with this red currant jelly sputum, which can lead to lung abscesses and empyema. You also could see it in meningitis or bacteremia, but think about UTI and pneumonia with red currant jelly sputum or cherry red sputum. And it is nosocomial, so it is typically originating in a hospital. That's oftentimes where you will get exposed to it, although you could find it in the world surround. Then our next gram-negative rod is E. coli. E. coli also is a lactose fermenter, and it's very motile. So it's very good at moving and maneuvering, and it's aerobic, so it actually is oxygen loving. It's most commonly causes a urinary tract infection, and we'll also see it causing diarrhea. And we're going to look at multiple types of E. coli here in a moment. It has lots of virulence factors, Fimbriae, so it can help with cystitis or pyelonephritis. Some strains have capsules, a K capsule, like pneumonia or meningitis. It does have an endotoxin, the LPS, which can affect its septic shock, lead to septic shock. It has a lot of antigenic variation, as we'll see, so we can see different types of it, meaning that it can evade certain aspects of the immune system or even treatment. And it also has several enterotoxins, one that's heat, and these would be our exotoxins, right? Our LT, which is heat label, ST, which is heat stable, and BT, which is like a Shiga-like toxin, so kind of like Shigella. And so what we'll do here is I think I'll be able to present these, and then we'll probably break for lunch. So after this little, this slide and maybe one more. So there's several different types of diarrhea causing E. coli, and we'll go through these different types. So ETEC is enterotoxic E. coli, and this gives you a cholera-like diarrhea. This is a labile toxin, a stabile toxin. There's no inflammation, no invasion past like the mucosa tissue. So we would call this a classic traveler's diarrhea. That's it. EIEC is entero-invasive E. coli. This is going to be more Shigella-like because it invades the intestinal mucosal cells. This can lead to actual inflammation of those cells and necrosis of those cells. There's no toxin produced, and you'll see more of a dysentery-like reaction. So instead of a classic like traveler's diarrhea where you might be affected, but it'll resolve quicker, this is dysentery. This is likely ending you in the hospital for dehydration, the EIEC, and it's invading the intestinal mucosa. You're necrotic tissue, you're inflamed. It's a lot more significant. EPEC is enteropathogenic E. coli. No toxins also produced here. So again, two no toxin produced forms. This adheres to the apical surface, so the lining of the lumen of the gastrointestinal tract, and it flattens your actual villi on that tract to prevent absorption. So where we see this really affecting people as pediatrics, I think of enteropathogenic as almost our pediatric EP kids, because it can prevent absorption of foods, of nutrients, of things of that nature, and can prevent, you can cause nutrient deficiencies quickly. Although it could affect adults, we typically see it more pathologic and pathogenic in children. And then EHC, EC, is the enterohemorrhagic E. coli. This is also Shigella-like. Some strains can even cause hemolytic uremic syndrome. This is your dysentery-like E. coli reaction, and we'll look at this one a little bit further. So your enterohemorrhagic E. coli, the classic like form is E. coli 0157H7. That's the classic form of this E. coli strain. It has multiple antigens, O, H, and K, that can interact and engage and cause more pathology, help with binding, etc. It has plasmids that can help it spread, help it become more virulent, increase the inflammatory response. It does have an exotoxin, Shiga-like toxin, which will cause kind of great gastrointestinal distress and can even cause actually break down blood capillaries and lead to fluid loss and hemolysis. And we'll also see disruption in these receptors for attachment. So we can see issues with our different plasma membrane. Yeah, issues with our plasma membranes, issues with our cells even being able to attach and being able to identify or even secure this bacterium and then phagocytose or eliminate it through our normal systems. So the classic disease is gastroenteritis, food fecal contamination. A complication could be hemolytic uremic syndrome, where you have anemia, thrombocytopenia, and then renal failure, because the breakdowns of these components are actually getting jammed up in your glomerulus and your kidneys and can lead to failure and extra work of the kidney filtration process. You can have septicemia, and in neonates, you can see a neonatal meningitis. But really, I want you to think about enterohemorrhagic E. coli. Knowing this might be helpful, the actual specific type. Shiga-like toxin causes hemolysis. Gastroenteritis is your classic condition, classic presentation that you'll see here. And a little bit more about Shiga toxin. I mentioned this already, but if you need to read it, it acts on the lining of the blood vessels. It will inactivate ribosomes and stops protein synthesis, which that means cells will die. You'll have hemorrhages, you'll have bloody diarrhea, but only your small blood vessels are affected. So it's affecting tiny blood vessels. It's not affecting the large vessels or vasculature in your body. On that note, before we get to Shigella, on this beautiful note of E. coli, before we go to lunch, talking about gastroenteritis, it always works out that way. I'm going to stop here, stop my share, check the chat real fast. Okay, great. Any questions that have arisen that I can help put to bed before we go on our lunch break? Or maybe we're all like zoned. That's fair. It's a lot. Okay. Well, when we come back, we will continue on the joyful world of our gram-negative bacteria. We'll have some more check our knowledge questions coming up, and then we'll move into virology. And we'll wrap up our day with immunology. So we're on track. Take a break for lunch, get off your computer, close down your laptop, close your eyes, eat some food, go outside. It's sunny, at least where I'm at. We'll come back at 1 o'clock, and then we'll get started again. Okay. I will keep this open if anyone stays on. If not, I'll let you back in after lunch if you sign off.